And with that, let's start diving in a little bit more. Something we recognize is that we are really trying to bring together the community, the academics, and the medical device industry together. And there's a confluence there. We can use the best of all of these parts of our BPO care pathway to really optimize it and help evolve it forward. And we are inspired by Defender Carmen Gonzalez, who reminds us, it's that sweet spot is between patient-centered medicine as well as evidence-based medicine. And as we dive in a little bit more, the manifesto, we're really defining that now in multiple stages, as well as being very thoughtful about how do we prioritize bladder health within the BPO care pathway, all the way from managing OAB, as well as how do we give the bladder an opportunity to speak out about surgical choice. Right now, we're focusing on the 5 stages of bladder health. Shout out to Defender Tarek Al-Saudi from the Scandinavian Brigade of Defenders, who's really been just a fun person and thoughtful and insightful, experienced person to speak with about the bladder health in regards to BPH-BPO. I mean, this is a guy who teaches on neurourology, who does multi-channel urodynamics daily, 6 to 10 of them a day. I mean, he has so much experience, and I've learned so much from him, and I think hopefully some of that knowledge will be passed on to you guys as well. And most importantly is recognizing that I think for our patients that we're going to be able to make that analogy and that connection between the heart muscle and the bladder muscle, right? They're both pumps, and the heart muscle pumps blood, the bladder muscle pumps urine through that prostate. And we've talked about it before, that prostate is the size of a golf ball, but in the shape of a mini donut. And we need to kind of keep reinforcing that concept about the donut hole getting tighter, as well as the fact that the bladder is an end organ. And how do we define that? Well, an end organ is that organ which is the final destination for a physiologic pathway. An end organ is that which is responsible for performing specific biological functions triggered by specific stimuli and signals. And there are so many organs that we prioritize, such as the lungs, the liver, the heart, pancreas, kidneys. And those are all transplantable organs. And there are only 2 major organs that are not transplantable, the brain and the bladder. And we've talked about this. And we need to allow the bladder to come onto the red carpet to bring it into the spotlight for what it is, which is an amazingly complex solitary organ that is so precious. And it is so complex, we can't even transplant it. So let's take better care of it. It does amazing things. On the far left here, it's able to contract under a coordinated pathway between the brain and the bladder. And on the right, it is then able to fill back up. And it's that amazing blend between the two that makes it special. And I think we need to recognize that it is complex. And we can see here on this schematic, everything from the brain to the spine, the sympathetic nerves, the parasympathetic nerves, the somatic nerves, all the way down to the urothelium. There's so much to it. And we tried to capture some of this complexity in this recent, last week we talked about male LUT. On the far left, you see the European Association of Urology. They have a beautiful spoken wheel, which talks about male LUTs and all these contributory factors. And as a tribe, what I wanted to do is get input from all of you by email, by text, by conversations, and I wanted to put it together where let's make the bladder the centerpiece. And you'll see that on the right, where in blue, the center is bladder dysfunction and damage, Detrusor overactivity and or Detrusor underactivity is a centerpiece to contributing to male LUT. And then in red, you'll see in the upper left there, aging of an end organ, BPH, BPO on the right. These are probably one of the most 2 significant factors that contribute to that dysfunction with voiding. And as we care for our patients, how do we begin to differentiate them? How do we treat them and manage them? And this connection between the bladder and the heart is something that I came up with because I needed something that my patients could relate to and your patients can relate to. And I just want to give a shout out to Defender Luca Cingolo from the Italian brigade, who's really taken this on and carrying this torch forward in Italy, in Europe. He took this and put an editorial in the Journal of Nature and prostate cancer and prostatic diseases, and he kind of summarized a lot of my thoughts. And there is a direct analogy to the heart that a lot of patients can relate to. If you look at the 5 stages, and I'm going to try and get rid of myself there so you can see it better. There's 5 stages. You can see it on the far left. In the middle are the key words that are patient-facing. And so as that prostate gets bigger, the donut hole gets tighter, and as a result, you have decreased flow or things slow down, or benign prostatic obstruction, the urodynamic term for when we have bladder outlet obstruction. Stage 2, the overactive bladder. We're seeing Detrusor overactivity urodynamically. Stage 3, the rebellious child. It's when you have urge urinary incontinence. You cannot control that OAB, and they're causing a leak on themselves. And then stage 4, the heart attack. We needed something to represent the clinical experience, the terrible experience of then going into retention, showing up in the emergency room, and needing a catheter placed into their bladder. And we called that the heart attack. And then stage 5, the heart failure. Once again, making that analogy to the heart, for those men who suffer from a weak bladder, a damaged bladder, a dead bladder, that may need catheters for the rest of their lives. And we needed to capture that concept for our patients. Now, you and I both know the analogy is not perfect because it's not really about ischemic heart disease like with a heart attack in stage 4, but it's really aortic stenosis or valvular disease. But we don't have time. Who's got time in their busy clinic to explain valvular disease to all their patients? We felt that given the pervasive understanding and familiarity with ischemic heart disease or heart attack, it was best to go in that direction. But look at all the work we do when we try and evaluate men for valvular heart disease. For aortic stenosis, we do CT scans, EKGs, echocardiograms, heart caths. We need to get all the data about that heart and about the valves so that we can make good decisions about their care. And so today I wanted to take that comparison between the heart and the bladder a little bit further. I wanted to talk about end-organ failure, specifically end-organ bladder failure, end-organ heart failure. And this is a great article here by Mostert in 2007, talking about the clinical epidemiology of heart failure. And there's so much we can learn from our cardiologist colleagues. Number one is in this table, it talks about heart failure symptoms and signs, and we do the same thing, right? We talk about the symptoms of BPO, decreased flow, intermittency, straining, hesitancy. We talk about the signs and the signs specifically, right? Do they have suprapubic fullness? What's their PVR? What's their uroflow Q max? What's the size of their prostate? All of these signs that became indicative of end-organ failure. And then here they go on to talk about the definition of heart failure. The one key word here is you read, number 1, symptoms of heart failure at rest or during exercise, and so symptoms and. Number 2, objective evidence of cardiac dysfunction. What they're trying to do is blend signs, symptoms and objective data. We need to do the same. Right now, so many of the guidelines talk about we're managing symptoms, but we really need to really push forward and evolve forward that we're preserving bladder health, and it's going to take a compilation of not just symptoms, but also signs and objective data. And as a result, as you all know at the tribe, we believe in linguistic determinism. Perhaps it's time to kind of evolve forward, as 94% of you all thought on LinkedIn, evolve forward the terminology for dynamic in the definition, which would be those tests that can help us acquire qualitative and quantitative data about bladder health, as well as about coordinated Detrusor function. It's a definition that we're still evolving. We'd appreciate your input from a lot of you, visionaries and leaders and academics, to refine that. Because when we think about that definition, well, then you can see here, we can now break up the types of urodynamic tests from basic to enhanced to advance. And you can see that at the top from left to right. And it's a progressive increase in the quality and quantity of data. So under basic would be like IPSS, the voiding diary, Uroflow, PSA, as well as using transabdominal ultrasound or transrectal ultrasound to get a sense of intravesical prostatic protrusion or prostate size or PVR. And as we go forward from left to right, enhanced urodynamics, probably the big two there are going to be looking at penile cuff test or external condom catheter method for testing to look at the pressure flow parts of pressure flow studies, which are really important, as well as now moving on to advanced urodynamics. The very best qualitative data is going to be cystoscopy, looking for the trabeculations, looking for that middle lobe, looking for cellules and diverticuli for a detrusor under duress, as well as multi-channel advanced urodynamics. That is the Cadillac. That is the gold standard where we have that filling phase, we have the voiding phase, and we can do things like video urodynamics, look at urethral pressure profiles, all the great quantitative data to make great clinical decisions. And then we learn from the cardiologist about staging, right? They are able to stage heart failure in 4 parts, A, B, C, D. And we know this very well. From an academic standpoint, we can see that what we're talking about with BPH, BPO. Because, let me pull that back here a little bit more. We can see that as a bladder begins to struggle from outlet obstruction, it has to first develop hypertrophy of the detrusor muscle, leading to compensatory changes, which leads to decompensatory changes that we see over time. You can see it in the bottom left, from normal detrusor to compensation phase to decompensation phase, done very nicely in this article by Bosch. So how do we apply these concepts academically, but also in terms that make sense to patients, right? We understand stage 1, benign prostatic obstruction, the decreased flow, the intermittency, the hesitancy, and the straining. But in stage 2, the detrusor overactivity, the urgency, frequency, getting up in the middle of the night. In stage 3, one of the most important stages, urge urinary incontinence. Why? Because it's not even covered on the IPSS. We need to help those men understand that, hey, they are progressing through the later stage of BPH, BPO of their bladder health, and they may need help sooner than later. And then stage 4, acute urinary retention. And stage 5, detrusor underactivity. That bladder's failing, decompensating, and needs our help. And so with that said, we came up with this bothersome, the 5 stages of bladder health, recognizing that we're not just treating and managing bothersome symptoms, we're treating bothersome fears. No man wants to enter into late stage BPH, BPO, just like no man wants to enter into late stage prostate cancer. And now we have a language, we have a structure with which we can now talk to our men, we can talk to each other, we can design research studies in a way to think of it in stages. And we are used to these concepts and stages in urology. And we look at end-organ kidney failure. The kidney, fortunately, is not as complex as the bladder. And you can see here on the right-hand side, on the left-hand side, we have the staging system from 1 to 5 for the chronic kidney disease. And on the right-hand side, you can see how they can break it up by GFR and by stage, and they can assess risk, which helps us understand urgency and helps us understand what we need to do and when we need to do it to help those kidneys. In a similar fashion, we now need to integrate all the stuff we've been talking about with that new schematic from ManVsProstate, talking about male LUTs, right? So it's not just about in the middle and there on the blue, bladder dysfunction and damage, but also on the far left, we see that underneath aging, neurologic dysfunction, pelvic floor dysfunction, metabolic syndrome, other causes as well, and polyuria. And how do we begin to integrate all that? And that's exciting because now we're entering into the golden era of bladder diagnostics, and we can now really refine our BPH, BPO care pathway. Something else going on here is understanding how do we assess risk? What factors are important? So in cardiac failure, on the left, you'll see things like age, gender, diabetes, things that we can relate to for bladder dysfunction, but as well as functional parameters or objective evidence. What is that Qmax? What is the urodynamics findings on multi-channel advanced urodynamics, or what are we seeing on pressure flow studies, as well as laboratory measurements and interventions received, specifically medications. Are we putting our men at risk by putting them on medications? And we're going to talk about that a little bit more right now. But you can see here on this slide, what they've done a really good job about is, you can see in the top left, does my patient have heart failure? What are the diagnoses? What are the risk factors, incidence, prevalence? When we understand that, how do we start to begin to screen them? How do we triage symptomatic patients? How do we screen asymptomatic patients? How do we get bladder health baselines for at-risk patients for bladder dysfunction? And if they don't have it, how do we prevent bladder damage and dysfunction for our men who are asymptomatic? And that's going to come with screening guidelines. And as we move farther down on this pathway, identifying types of heart failure causes and contributory factors. And then how do we initiate therapy? How do we initiate management plans to help our men? Does it include medications as temporizing measures, not therapeutic measures? Does it involve surgical deobstruction when warranted, with the right technology for the right patient, for the right prostate, at the right time? How do we integrate all of these things? And then how do we create a multimodality therapeutic plan when we also have to consider secondary overactive bladder or Detrusor overactivity? And how do we stage either therapies for that when it becomes refractory after deobstruction? And so we can see here this in summary for ManVsProstate on the far right. Let's start thinking about screening asymptomatic men. For right now, we propose the age of 50, because looking at the data, it's probably going to be somewhere between 45 and 55, depending on where you are in the globe and depending on your healthcare system. And then when we think about temporizing measures in the bottom right, medications are temporizing measures that are not a mechanical solution for a mechanical problem. They are in the same category as placing a catheter for a guy who shows up in retention. It buys us time to do a comprehensive evaluation, to get a bladder health baseline, so we can figure out what the next course of action should be for that prostate and for that bladder. And at the top, once again, it is all about preserving bladder health. And on the far left, as we go down, let's do the proper bladder health counseling. Let's triage our patients appropriately who are symptomatic. If they have an IPSS greater than 8 and above, that's an indicator. Do they have a history of urge incontinence? Make sure we ask about that, because the IPSS does not cover it. Do they have a history of spontaneous retention? Or in combination of some factors, like an IPSS 8 and above, in conjunction with a Qmax less than 15 and or a PPR greater than 100. Let triggers, depending on where you are and how your healthcare system works, let those be triggers for bladder health baselines, as we see at the bottom left, so we can risk stratify which bladders are in danger of being permanently damaged, irreparably damaged, unless we intervene in a timely fashion. And you can see that in the middle, which is, yes, it's not just about prostate size, but it's also about prostate shape, Detrusor function, as well as when we talk about shared decision-making 3.0, where it's not just the patient, provider, and the healthcare system, but we have to let the bladder be involved in this discussion. And here we can see it again, the triangle of triage on the left, IPSS 8 and above alone or in combination with a slow Qmax or elevated PPR, or a history of urge incontinence or a history of spontaneous acute urinary retention. And on the far right, get those bladder health baselines. At a minimum, let's get cystoscopy. And if you have availability to it, let's get enhanced urodynamics or advanced urodynamics like multi-channel urodynamics, which gives us the very best data. And don't forget to ask about urge incontinence for our men, because it's not covered on the IPSS, and too many men are suffering in the shadows. And here we are. One of the last tables on that paper was looking at the risk of medications, the risk of developing heart failure when men are on medications for hypertension. We can apply that concept. In fact, we have been. And you know that with the COMBAT trial. We see that with the COMBAT trial of dutasteride and tamsulosin. As many of you guys know, almost 5,000 patients were followed over time. And we saw that, yes, it can improve the IPSS scores if our prime directive is just to manage symptoms. But our true north, our North Star, is really to prevent bladder damage, bladder dysfunction to help preserve bladder health. And as we look at the 4-year data and look at clinical progression, we are very interested on how many men went into stage 3 incontinence or urgent incontinence or stage 4 acute retention, those later stages of BPH, BPO. And we can see that even though, yes, more medications can reduce that risk of retention, for example, here, or BPH surgery, it does not eliminate it. Medications are temporizing measures. They don't fix the problem. BPH, BPO is a mechanical problem that deserves a mechanical solution when warranted. And we need to recognize that medications have their role. We are not anti-medication. We're just pro-data. We're pro-deobstruction at the right time, for the right patient, for the right prostate, within the window of curability. So once again, how do we now begin to evolve forward? Here we talk about a different perspective on male LUTs. And the next step is going to be, how do we apply these concepts so that we can intervene within the window of curability on the right-hand side there before bladders decompensate? How do we prioritize the bladder on the left? How do we allow the bladder to speak up and be on the red carpet and be part of the conversation of shared decision-making? How do we give it a chair and allow it to sit at the table and give voice to its concerns so we can also take care of it? And remember, the combination, the bladder health baselines that we've been talking about, cystoscopy and some combination of basic, enhanced, or advanced urodynamics, is our stethoscope. As a minimum standard, everyone should be doing cystoscopy. There's so much we can learn: intravesical prostatic protrusion, trabeculations, other pathologies, in some combination. The best is going to be the complete level of diagnostics, where it's advanced cystoscopy and advanced multi-channel. But do what you can. More importantly is get the data. Prioritize data over drugs. Drugs are temporized. They have their role. But let's get the data. Let's get those bladder health baselines. And let's let the bladder have a seat at the table. This is a slide I show often on the far left-hand side with that bladder health baseline with cystoscopy and, in this situation, multi-channel, advanced urodynamics. But whatever you have, when you see, for example, that the bladder is struggling with true bladder obstruction or Detrusor underactivity, in those situations, perhaps you may have to consider or place more weight on technologies within the categories of IST and MOST that can maximally deobstruct. So those TURPs, those HOLEPs, those enucleations, those robotics, simple prostatectomies. But recognize that in that shared decision-making process, one size doesn't fit all. And you also have to prioritize a patient's vitality, his sexuality, his ejaculation, as well as treatment durability, economic sustainability, as well as the window of curability before you make those decisions. So thank you all for being defenders of the Detrusor. Sorry about that glitch with live streaming to LinkedIn. I'm going to try and repost this later. And thank you for all you guys do. And let's go save more bladders. All right. You guys have a great one. And we'll talk to you soon. Take care now. Bye.